All right, our last presenter is Dr. Charles Gatt. Dr. Gatt is um, an orthopedic consult to Rutgers and Rider, and also probably his most favorite school is Montgomery High School. He's also the director of the residency program at Robert Wood at the medical school, and firmly believes that everybody needs to get their ACL redone.
Yeah,
Laser
hopefully,
pointer and forward and back.
hopefully this isn't an editorial about my surgical skills, but anyway. So I am going to talk to you today about non-operative management of ACL surgery and is there a role for it? So the question is, that's the question. Is there an option for non-operative management patients with acute ACL tears? I'm talking about patients that you guys all take care of, athletic trainers. These are high school and college students. When you're old like me, like if I tear my ACL, I'm not getting surgery. I'm done. But for the patients that we are taking care of that want to get back to sports, is there an option? So, I did one time, I remember sending one of my first patients to PT talking about non-operative management, and they called me back the same day that they went to their first PT visit and said, my therapist says you're crazy. Like there's no such thing as non-operating on an ACL. I realized, that, the perception out there is now that, it's the quote unquote knee-jerk response. You tear your ACL, you get surgery, right? But that may not always be the case. So I'm not a conspiracy theorist. All right. I do believe men landed on the moon, and I don't think the world is flat. And I do think that people need ACL surgery, but sometimes you might have an option. So let's just look at some cases, and I bring these people up to patients. So I'm old enough to remember Garrison Hurst, and Garrison Hurst was third in the Heisman Trophy voting. He won the Doak Walker Award, best running back in college football, and he was the third pick in the 1993 NFL draft. He went to the NFL Combine, where his knee was examined by every team doctor, and they found out in the NFL Combine that he was ACL deficient, and nobody knew. Now, this happens at the Combine because the guys who get hurt, like if they can hide an injury, they try to hide an injury, but they can't because they have some of the most skilled orthopedic surgeons examine their knee. So I was like, it made the papers like, oh my God, the third person in the Heisman Trophy voting is, was completed his college career with an ACL deficient knee. Now he did go on to play a pro career. In his first season, his knee subluxed, they ended up with an ACL reconstruction. But the point is, he finished his college career and nobody knew. This was a total surprise. I found out that Hines Ward played his NFL career without an ACL. John Elway played his NFL career without an ACL. Those are things that I didn't know until recently. And then there's always Spencer Lee, right? So this is a big one. Just a few years ago, he won his third Division I NCAA championship, and he with bilateral ACL insufficiencies. And he actually tore the one ACL or re-injured it, I think, about 8 days before the tournament. And he didn't tell anybody. He told nobody, except one of his trainers, and he got put him up in a big brace. And he wins a national championship for the third time, goes on TV, and then says, you know what? Both of my ACLs are out, and I just tore the other one like 8 days ago. And the other person in the room was like, I can't believe you did that. And he goes, excuses are for wusses, right? That's like a very famous line in the wrestling world. But the guy did it, So again, these are people competing at the highest level of competition with ACL deficient knees, and they were successful. So it's not impossible. It's the exception to the rule, but it's something we do have to consider. So I'm just going to run through a few cases that I've taken care of and not that long ago. So here's a high school football player. He was a senior, sustained a non-contact injury. His exam was consistent with an isolated ACL tear, not a big MCL sprain or anything. Got an MRI. It was an isolated ACL, maybe a mild MCL, but no meniscal damage. And the kid wanted to wrestle. He actually liked wrestling better than football. So the question is what do? They tell us, well, it's your senior year. You've invested all this time and energy into your athletic career. You're going to graduate next year. He wasn't going to compete in college. What do? So more to follow. Second case, high school girl, junior, good basketball player, but an even better cross-country runner. Tears her ACL playing basketball. She got an ACL, mild MCL, and on her MRI, she showed a small kind of peripheral medial meniscus, but very small. And she was, like I said, she was being recruited for college cross-country. So, considering the timing of surgery and everything that was going on, if she had ACL surgery, she probably would have had to forfeit her senior year of cross country, which would in fact, she thought would have a big impact on her recruiting for college sports. Okay, so more to come. And finally, this is a little bit of a zebra, but it's still an interesting case. College football player, middle linebacker, good. I think maybe even potential captain on his team. And he had a prior ACL reconstruction, wasn't really doing well. He didn't have great range of motion. He didn't really feel good about his knee. And she said, I can't play football with my knee like this anymore. So he went to New York and said, they were told him, well, you know, your ACL is not really put in properly. We're going to have to take it out, bone graft your tunnels, and do a 2-stage revision. That's a year out of his life, at least a year out of his life, to get him back to play collegiate football. That happens basically his college career is over. So I saw him and said, well, you don't maybe have to do that. Maybe I'll just shave out your ACL and we'll see how you do. So more to come. So let's talk about the history of, you know, non-operative management of ACL surgery. So Frank Noyes really came up with this term that I think we use all the way in today in 2024. We call them copers, adapters, and the non-copers, right? So copers were people who had tore their ACL. This is all the way back in 1983. And despite the fact they had an ACL tear, they could live the lifestyle that they wanted to live. They weren't necessarily all high school or college athletes, but people who tore their ACLs. And then there were the adapters, people who, if they tore their ACL and they changed their lifestyle a little bit, or maybe a lot, they could live without an ACL. So like in the famous words of Tim Hosey, stop playing soccer and row crew, right? There you go. You know that one, Kathy? And then there were the non-copers. These are people who have instability with daily activities. So just walking out of the office door and turning to the right or left, your knee gives out or buckles. Going up and down the stairs, the knee gives out or buckles. And back then in 1983, when I was growing up in orthopedics, you know, that was, we thought there were 1/3 of the patients were copers, 1/3 were adapters, and 1/3 were non-copers. And in the general population, that may still be a realistic estimate. Although I don't think most people kind of apply those numbers in 2024. So then, you know, Dale Daniels, this is in 1994, and Dale Daniels is really one of the champions of ACL research back in the early 90s. When he said something, everybody listened. So he looked at the Kaiser group and looked at over 300 patients who had been managed with ACL injuries. And this was before like routine MRIs were done the day that you injured your ACL. And a lot of these patients never even had MRIs. They were managed because they had an acute hemarthrosis, and he did a KT1000, which Dino just showed you what that is. And if they had, you know, he showed that with an acute hemarthrosis and a KT1000 side-to-side difference of greater than 3 millimeters, there was 90% accuracy for an ACL tear. And this was based on diagnostic arthroscopy because, again, back then you could just do a diagnoscope and see what's going on. We don't really do that anymore because of MRIs. And he broke his patients in follow-up, and the follow-up was about 5 years. And he had them into patients that were early stable, meaning they had an ACL tear, their KT1000 was less than 3 millimeters side to side, and they didn't get a reconstruction. Patients who were diagnosed early, and that's, you know, within the acute phase, and elected to not have a reconstruction, even though they were greater than 3 millimeters side to side. And then he looked at the patients who were reconstructed early, meaning 90 days, within 90 days of their injury, or a late reconstruction done 90 days after injury. And what was interesting about his outcomes, I think, is that if you look at the patients that had surgery, and this is the X-ray score and the bone scan score, he evaluated them for signs of arthritis. The patients who had surgery had more arthritis than the patients that didn't have surgery, even if they were considered early unstable. So they had a KT1000 greater than 3 millimeters. Now, I will tell you that you have to take this with a grain of salt because the surgical techniques these were actually the surgeries were done in the late 1980s, were nowhere near where we are today. So they were very different. They were, you know, all different types of reconstructions, over the top reconstructions. I'm old enough that I've seen them all, and it's very different than what we do today. But what was another thing that was interesting is that he found out that the patients who were early stable, who hadn't gone on to reconstruction, if you followed them up, there was no increased risk of meniscal damage in those patients. We always tout that the meniscus is the big problem. Like, are we damaging the menisci if we don't do the reconstructions? And he had a large number of patients to show that if they remain stable, they didn't do any increased meniscal damage. So again, you have to take, this is a paper that people refer to a lot. Understanding the techniques are different than our modern techniques. It is important data. So this was an interesting paper, and this was, not so old. This is a 20-year follow-up study on 50 patients, 25 treated operatively, 25 treated non-operatively with ACL insufficiency. These were young patients, in their early 20s. They had Tegner activity scores of 9, which means they were 1 score below being a professional athlete. So it's as high as you can get without being a professional athlete. And this is a follow-up study of their 10-year data, but if they compare their operative and non-operative patients, you see that their lysome scores were no different. Their IKDC scores were no different. Now, these IKDC scores are a little bit on the low side. And by the way, these patients were managed with transtibial BTB ACL reconstructions. So pretty much modern techniques. And you can see that their Tegner scores were high at baseline and dropped down, to 6 and 5. But is that from the ACL injury or is that from life? Right? Like they were 25, now they're 35, now they're 45, right? So interesting data to take into account that really there's not much difference. Then they looked at the radiographic scores. So again, like I think somebody pointed out, it was Dino saying that, well, we have to, we want to do ACL surgery so you don't get arthritis. Well, it doesn't matter. The operative and the non-operative patients had the same exact KL score as Kellegrand-Lawrence, which is a rating of osteoarthritis at 20 years post-injury. So the ACL surgery didn't really change the incidence of their arthritis at all. So their conclusions were, even with high-level athletes, there's not evidence to state that ACL reconstruction is superior to non-operative treatment. But again, remember, these 25 patients that were treated non-operatively were copers. They were patients who didn't have instability. All right. And then also, as far as the long-term, non-operative treatments as suitable therapy for ACL ruptures, again, that may be in copers. So you have to be careful about how sometimes these broad-reaching conclusions get totally misinterpreted, and that's a big problem. This was a review article done by, I know Photius Jamarcus, I don't know how to say his last name, but he's actually a student from our medical school. Really nice review of operative versus non-operative management of ACL surgery. And what they found is they tried to do a literature review and found out there were only 3 randomized prospective studies ever published comparing operative to non-operative treatment of ACL injuries. And for 2 of the 3, the ACL surgery was performed with suturing the ACL back together. There was only one paper and only had 32 patients that had ACL versus non-operative management. So what they found is that there is no good data. And honestly, we're never going to get that data. No one is ever going to have the spine to run a randomized prospective study of op versus non-op for ACL. So forget it. But if you look at their scores, these are some of the conclusions they made based on an extensive review of literature that's, it's good, but it's not great. So patients with ACL injuries and concomitant meniscal injuries should have early reconstruction. That makes a lot of sense. Patients with isolated injuries intending to return to greater than 4 hours of level 1 sports, cutting, pivoting sports, probably should get surgery. But patients considering non-op rehab for ACL injury can delay the reconstruction and see if maybe they can become a coper. That's an option. And then perturbation exercises, that's a fancy word for me. I always call it proprioceptive training, but I actually, get it. That's a very important point of non-operative management of ACL surgery. Now, the things that they pointed out again in these studies is that if you were a coper, you were not at increased risk for meniscal injury compared to somebody who didn't have an ACL injury. And they also found out that they couldn't prove in the patients that were copers that they would have less osteoarthritis if they were treated operatively compared to non-operatively. So again, if your knee is stable, you're probably not going to go on to arthritis any more than if you had surgery. And if you go back to Dale Daniels' data, then you could say that, people actually get more arthritis if they have surgery. But what they pointed out, which I thought was really interesting, is there is no screening tool. Like, how do you decide who's a coper? All right. And that's our challenge. We don't have that answer. And they made it very clear in the paper that we don't have the answer. But down at the University of Delaware, Lynn Snyder-Mackler's career has been on trying to treat patients non-operatively for ACL surgery. and coming up with a screening tool. And they've done tremendous work. I mean, I've seen her running around the AOSSM since the first time I went to the meeting. She's like, and you got just done tremendous work on this. So they really did develop what they consider a pretty good screening tool. And it was interesting watching Dino's return to play conversation and how it applies to determine who's a coper. So this is this tool that they use at University of Delaware, and they're very strict about it. They do the unilateral hop testing, single leg hop for distance. This is all developed by Frank Noyes, triple crossover, straight triple, and 6 meter time. So that's an objective measurement of what they can do. And they have to have a asymmetry difference of less than 10%. The knee outcome score activities of daily living is about a 14-point questionnaire where they ask, about how does your knee function during routine daily activities. And they have to score above the 80th percentile. There's this global rating of knee function, which is basically a SANE score from a 0 to 100. How does your knee function? It has to be above 80. And then lastly, the number of giving way episodes with ADLs. One episode of instability with ADLs, you're out. You're not a coper anymore. And that's what they tell the patient strictly, okay? So this screening tool they use to determine if patients can be enrolled in their non-operative management. Then, she has a very detailed rehab protocol, starting with easy perturbation exercises and getting more advanced and getting more sports specific. And this occurs over about a 6-week period. Obviously after the acute phases have occurred. If somebody has a giving way episode during this time, they're out. They're no longer a coper. And it's one episode. It's like, you have one episode, you're out. Okay, so again, their data is really interesting, because what they found, if patients pass their screening tool and they successfully completed their rehab program, they had a 72% return to sports rate at the same level of participation as if they hadn't, compared to the patients who failed. So 72% is way higher than the literature. If you look at the literature across the board, it's in about 35 to 45% range, but their criteria are extremely strict, okay? So, that's kind of, that's about it for the literature that's out there. There's not a ton out there. So what do? Like when I see an athlete from, young person who's gonna consider treating non-operatively, what do I wanna know? Well, the first thing I know is it an isolated ACL tear? Now, everybody has a little MCL tear, maybe a little LCL tear, but they're very minimal. I call that an isolated ACL tear. That's important. If it's a grade 3 MCL, grade 2, grade 3 LCL, like they're out. They're not. You don't even really give them the option. It's not really feasible. And then the side-to-side Lockmans in my own hands is very important. Now, the nice thing is I can send them upstairs to Dino and get a KT 1000 and actually document what their side-to-side difference is. But before we dug our KT 1000 out of the closet, which it actually took us a while to do, I mean, you can examine people, and some people's knees are loose and some people's knees are really loose, right? And that's the difference. So if I have somebody who's like, they have a Lockman, they kind of have a spongy endpoint or something like that, it's not that bad to side, I start thinking, maybe this can fly. It's difficult to get a pivot shift in the office, but if you can get them to relax and, with time, it's not maybe in the first office visit, but the second or the third, if they have what's called a pivot glide, where they don't really clunk when you pivot them, but they just kind of, you can see their knee shift, but it's not bad. Again, that's an option. And then of course, now we get an MRI in everybody, so we can look at that. And what do I look for? Well, the one thing I like to see is, I'm always happier when I see a femoral avulsion injury, because I feel like the femoral avulsion injuries scar onto the PCL, they scar onto the wall lateral femoral condyle, and I think that provides some inherent stability to the knee. Again, they can't have any significant collateral ligament damage. They definitely can't have a significant medial meniscus tear, because those are the ones that we can take, a repairable medial meniscus and convert it into a unrepairable medial meniscus. And one thing I forgot to talk about in the prior studies is all these studies that looked at osteoarthritis, if they had a meniscus tear at the time of injury, their risk of osteoarthritis was higher than if they didn't. So the meniscus is still important. And now that we are paying attention to root tears, if we see a root tear, like they're out. That you can't let a young person beat up their meniscus if it's a root tear. So these are the things that I kind of look for on my clinical evaluation if I'm going to offer the patient the opportunity to go back and play non-operatively. And then recovery and rehab. And, Dino talked about this. Time is really a big deal. But First, they have to recover from the acute injury, okay? Second, you got to get them into physical therapy with a derotational brace on. And that's important because, they can't just do this on their own. You can't say, well, give your knee 6 weeks and see how it goes, and then it's time. Because I think the big mistake is to try to get them back too soon. They have to have all those asymmetry indices appropriate for them to even give it a try to go back. Because if you let them go back too soon, their knee's going to sublux, and that's going to be it. So if we go back to the cases, here's this fella was the football player. He wrestled successfully his wrestling season. Had maybe 1 or 2 minor tweaks to the knee, no effusions, finished his wrestling season, and a week later reconstructed his ACL, and he's off to college. Happy guy. This girl is running collegiate cross country without an ACL, sent me a letter from college thanking me for not reconstructing her ACL. She should be thanking Dino for not reconstructing her ACL, because I didn't do anything. He did all the work. And she's having a great college career and very happy. And this fella took out his ACL, played his entire college career, never had a problem with his knee. And now he's in real life and never had an ACL reconstruction and loves it. Now, again, I told you this is a zebra, and I learned this, from John Bergfeld. This fella's knee was over constrained. It was too tight, right? He couldn't flex all the way. He couldn't extend all the way. And I think what happens in knees like that is they get a capsular contracture. So by taking out his ACL, I got rid of the over constraint of his knee, and this thickened, scarred capsule provided him the stability he needed to play collegiate football. And he's playing Division I football, 1AA. So, he's playing at a pretty high level and had no problem with his knee. So again, that's a rare case, but interesting, I must say. But, again, in 2024, I love this editorial. This is written by the editor of American Journal of Sports Medicine, Bruce Ryder, and his career is longer than mine and considered one of the godfathers of sports medicine. We used to talk about the ACL, like, oh, you need the ACL for stability. If you tear your ACL, you're going to get arthritis. And, Bruce really gave this great editorial that one of the main reasons we're doing ACL reconstruction surgery is to protect the meniscus. And it's the meniscus tears that cause arthritis later on in life, if that's really what our main, concern is. And I kind of always, I think about this more and more as time goes by. It really is the truth. Damage to the meniscus is really the beginning of the end of the knee. It may happen 5 years, it may happen in 10 years, maybe in 20 years, but when you lose a lot of meniscal tissue, your knee is doomed. So not everything really works out great, does it? So I just showed you 3 success stories, but this is another young patient that I just took care of. Tore his ACL at the end of his junior year in high school, femoral avulsion type injury. Whoops, sorry. He did have a little bit of a meniscal tear, but actually no, he didn't have a medial meniscus tear. He was fine playing lacrosse and soccer. Desperately wanted to play his senior year. Talked to him about the pros and cons. Talked to his parents about it. Plays the whole soccer season. Awesome, no trouble. Has the winter to kind of cool off. Goes out for lacrosse. Plays about 1/3 of the lacrosse season. Starts to get some minor instability episodes in his knee, but really wants to play. Then one day comes in with a locked knee. Big bucket. So he sustained a bucket tear. Now, obviously at that point, his career was over from a standpoint of high school lacrosse. Booked him for surgery, did his ACL reconstruction, and repaired his medial meniscus. But his long-term outcome is worse now because he had a bucket handle medial meniscus tear that I had to repair. I mean, whether my repair heals or not, it doesn't matter. He's still going to have, his risk of osteoarthritis is higher because I had a bucket handle tear. So, nothing's easy, right? Everything has, and so I find that it's important to have these discussions with the patients and the family. So I do think in our population of patients, non-operative management is feasible for a short period of time. You want to get somebody through one season. I had a female athlete who was the goalie at Hunter and Central, tore ACL before senior year, said finish it out, reconstruct it after. And then fast forward like 10 years later, she interviewed with me for our orthopedic residency. She did okay. I think counseling is very important. Not only do you have to tell them, it's not all about getting back on the field. Because again, how many of these kids are going to become collegiate athletes? Very small number. Are any of them going to the pros? Not in my, very few, right? So you have to tell them, I know you want to play, and their parents are there sweating it out. And I say, I know you want to play, but your parents care about how your knee is going to be when you're 40 years old. They don't really, at this stage of the game, they don't care if you play. They want to make sure when you're 40, you're a healthy adult who can play with your kids. So I have to have that conversation with them too. And I have to tell them, this is not definitive treatment. If we treat you this way, as soon as season's over, get on the books and we're fixing it. And that's how I handle it. But you have to tell them it's got to take a lot of rehab. You have to wear a brace, and don't try to go back too early, because if you go back too early, you're just going to probably do some damage to your knee. And be realistic about your expectations. I tell them all, like, I say, if I was going to bet, I'm not going to bet my house on it that you're going to succeed, because there's the chance of you playing a high level cutting or pivoting sport without an ACL and successfully making it is maybe 15% at the best. So they have to know going into the season that that's the case. Kid from Sayreville High School. Sayreville was going to the state championship there, no question about it. They're starting running back tears his ACL. But there's enough time to get him ready for the state game only, right? So he does the whole thing, works with Dino, works his butt off. He's actually practicing, having no trouble. And the state game that year is at Rutgers. So team's all warming up. He runs out of the runway to go onto the field, and his knee subluxes. Doesn't play in the game, So again, that's why I tell them, like, the chance is only 10 to 15% that it's going to work. If you can't blow smoke up there and tell them, oh, this is going to work, because it's probably not. And I think they have to know that. But if you give patients appropriate expectations, they're not disappointed when it doesn't work. If you tell them something that's inappropriate, then, they're going to be disappointed. So I think it's an interesting topic. I think it's the exception to the rule. But I think if you use, good clinical skill, look at the patient, look where they are in their lifetime, what their goals are, what their expectations are, this is an option for a small subset of patients that we take care of. So that's it. Thank you.